Hi, my name is Emily DeMaio, and I'm a fourth-year medical student at Emory University in Atlanta, Georgia. I currently serve as the Vice President for the AMSSM Medical Student Interest Group, and I thank you for either joining us live or watching this recording of A Day in the Life as an Orthopedist. So we have four wonderful orthopedic surgeons who will be joining us this evening. They have a myriad of experiences covering local teams, professional teams, and the like. So I will go ahead and give a brief introduction, but really leave it up to the surgeons themselves to tell us about them. So this evening joining us, we have Dr. John Bergfeld. He is a current senior surgeon in the Department of Orthopedic Surgery at the Cleveland Clinic. We have Dr. Justine Crowley, who is at the Orthopedic Surgery Specialist, and she is the Chief of Surgery at the Salem Veterans Affairs Medical Center. We have Dr. Jones, who is the current Section Head of Sports Medicine and Cartilage Restoration at the Ochsner Sports Medicine Institute. And we also have Dr. Trey Remaley, who is at the University of South Florida in Tampa and also works at Shriners Hospital for Children. So without further ado, I will go ahead and let Dr. Bergfeld get us started with his own story.
Okay, Emily. Well, I'm probably the senior member here, and following the sort of way you asked us to do it, my training background, my residency in orthopedics was 3 years. And when we finished in 3 years, we were expected to do everything. There was no subspecialization. And no fellowships. So I sort of got interested in orthopedics because then we all moonlighted. There was no colleges of emergency room physicians, so everybody moonlighted. And I was in the emergency room one day, and a doc came in and said, "Boy, I really need somebody to help me with a high school football team." So I played football and sports in college, and I thought, well, this might be pretty good. So I went with him to the game, and I was hooked on sports medicine. And at the end of the season, about 5 high school coaches contacted me and said, "Can't you get me one of those interns to work with my team? I really need a doctor." And there was no sports medicine. My chairman, Dr. Kendrick, says, "What the hell is this sports medicine stuff you're talking about?" About that time, the television became important in sports, and Dr. Nicholas was taking care of a quarterback named Joe Namath and made headlines in the paper. And so that's sort of how sports medicine got going. Why did I choose that specialty? As I said, I played sports in college, and here was a chance to rub elbows with coaches and everybody other than doing the routine stuff that I had to do in orthopedics. Impact decisions along the way. One was first to practice at Cleveland Clinic. I practiced there because all I did is take care of patients. They paid me a salary, and I took care of the patients, and I didn't worry about anything else. And also I was able to, at that time, 20% of my time was spent in research, and I was able to do some primary things. So that was a very important decision for me. The other important decision, which I didn't make, but the government made, there was a draft. And when I finished my training in orthopedics, Vietnam, I got activated during the Tet Offensive. And I don't need to tell you, orthopedists, what I saw there on a daily basis. Horrible things at the U.S. Naval Hospital in Philadelphia. And then I went to the full-time at the U.S. Naval Academy. They were looking for a team position, and I played sports and was involved in the sports programs there at Cleveland Clinic. So I spent 3 years at the Naval Academy as a team doctor at the Naval Hospital in Annapolis, where I took care of the walking wounded, we called them, the Marines, and the Naval Academy. So right out of my residency, I was a TED team physician for the Naval Academy, and that was big time sports. And of course, I fit right in, and I like that. So that was an important decision made for me by the government. Now, my typical day is a little different now because I've turned over all the things, but a typical day when I was very, very active in taking care of athletic teams. On Saturday would be going to the game, traveling to a game or a home game, going to the training room to check the players before Sunday was a game, and that was an all-day affair. Monday was my clinic. Tuesday, surgery. Wednesday, half-day clinic. The other half of the day, I went to the teams. Now, I was also a high school team doc, and this isn't just the pros. The college, Baldwin Wallace College, when I would do that, my afternoon was spent in the training room. Then Thursday was surgery. Friday was my research day. And the way the Cleveland Clinic was set up, I was free and was able to do some important research, especially on the posterior cruciate ligament. And then Saturday, traveling again. Practicing it. So my big decisions that I made was one, hiring John Lombardo as my primary care team partner, because I've always felt that the team doctor is a primary care doc and an orthopedist. And I hired John Lombardo. And this is before AMSSM was ever founded. So John was one of the founders, and I'm actually a original member of AMSSM. And I'm very proud to say that 4 of my fellows have become the president of AOSSM. 5 have become president of AMSSM. So I was very supportive and realized the role of primary care sports medicine along with me as the orthopedic surgeon. So we were a team, and every team I've ever worked with, I've always had a primary care team position. The sports medicine, passionate about it. What was great, I was able to take care of ballet dancers. I'd never seen or heard of what a ballet dancer was, but they are athletes, there's no question. And then the ski team, I had the opportunity to be with the U.S. ski jumpers and cross-country skiers, not the ones that everybody hears about. Nobody could name you a ski jumper.
Go lay down.
And traveling around the world with them was a lot of fun. So I just was very fortunate to practice something that I loved, never felt that it was work. And I'll finish up now that I've done it. Everybody knows me from taking care of the Browns and the Cavaliers, but they say, well, aren't you a sports medicine doctor? Well, now I've turned those all over. I still am. My sports have changed that I take care of. Pickleball, jogging, tennis, badminton, no football, baseball, basketball, all those other sports about older people that want to stay active. And average age of my clinics nowadays are about 65, but they're all people that come in for 2 reasons. 1, I don't want to have surgery. And 2, I want to keep going, playing golf. And that's what my sports medicine practice is now. So that's it. Can't hear you, Emily.
Thank you very much, Dr. Bergfeld.
Okay.
Next, we have up Dr. Crowley.
Hi. So yeah, I've been around sports my whole life, like a lot of folks who end up in sports medicine. I had a first aid kit before I had first aid stuff and was the team doctor, at junior high school when kids would come to me for Band-Aids. And then I went to undergraduate at Colorado College and was a training room aide and learned a lot of sports medicine on that side, and actually learned some of the bureaucratic stuff that becomes important when you're on the doctor side of reorganizing we called it the Green Book of Bureaucracy. And back in the days when we had 5 1/4-inch floppies, and then became an EMT, worked in rural Texas as an EMT, worked in New Hampshire as an EMT, worked as a unit clerk, then went to medical school and chose to go to osteopathic school because the athletic trainers and physical therapists that I'd worked with at Colorado College did manipulation, and I knew that having hands-on an athlete could make a huge difference, and chose orthopedics pretty much 3 weeks into med school because I loved anatomy and did not want to do bowel resections, and I love tools and I love fixing people, and orthopedics lets you work with young people and old people and get them back to function. You do get to have cancer conversations, but not nearly as many as you do in other surgery specialties, and was the first woman to graduate from the Oklahoma City DO residency program, and then ended up choosing to do a trauma fellowship, not a sports medicine fellowship, because we did so much sports medicine in our residency, and I wanted my EMT side still comes out once in a while, and I like handling disasters and disaster response and that kind of thing, and had worked, we had several heavy sports medicine guys, so we covered high school games as as residents, we went out and covered football games and worked with teams that way. And then was working with a practice in Colorado Springs. My life took a little bit of a detour. I went to Haiti after the 2010 earthquake and was there for 6 months and had a whole different perspective on what it means to practice orthopedics and what it is to practice an austere environment. And you say, how does that translate to sports medicine? Well, I've been to places like Kyrgyzstan and practice in places where I became the team doctor for multiple teams because of what I carry in my kit. So austere medicine, emergency medicine all come into handy on the field side. I've been an ultimate Frisbee player since I was 18 years old. It's actually how I got involved with AMSSM. One of my colleagues, Dr. Leslie Yen, who is also an elite ultimate player, and is part of, with me, the USA Ultimate Working Group, Medical Advisory Working Group. Got me involved with AMSSM. So that's why I'm here tonight. But I work with USA Ultimate with their national team, several different delegations. I'm the chair of the working group. I work with USA MAS Wrestling. The word is MAS, it's Russian stick wrestling. And I work with a local police fire safety football team. And at the VA, I am the shoulder specialist and the sports medicine specialist. I take care of shoulders. I take care of chronic exertional compartment syndrome. And then I also take care of my colleagues who come in and say, I threw out my, can you fix me? I just did that this morning. Horrible wiffle ball injury to one of my CRNAs. And with the last few, it's been 3 months now, 3.5 months, I've been serving as chief of surgery. So I'm an orthopedic surgeon who is serving in the administrative role, running a surgical department with over 50 employees. So that's been a whole different learning experience, a whole different experience, but it's been good. And the pandemic, it has changed a lot, but with the teams I travel with, we have athletic trainers and physical therapists that go. And as a DO, my hand skills come in handy and my time in the training room comes in handy, because when you've got 75 athletes, you get pulled into tape. So don't forget that sometimes you have to be the athletic trainer on the field. And that's my sports medicine life.
Thank you, Dr. Crowley. Next up, we have Dr. Jones.
Oh, thank you very much, Emily. Thanks for having me. And I wanted to just say that Dr. Bergfeld is one of the godfathers of sports medicine. So you guys are hearing from one of the legends. So I started in sports medicine, as everybody probably on this call, with some interaction with sports myself. And I was playing soccer when I was 15, and I tore the anterior cruciate ligament in my knee. And it was unfortunately 1979. So Dr. Bergfeld knows what we were doing with ACLs at that time. And they had this thing called the Ely procedure they did, Dr. Bergfeld, where they took my iliotibial band, rolled it up. He probably did this procedure, and went over the top with it, then tied it down, put me in a cast for 2 months.
Yeah.
That was a plaster cast for 2 months, right? Remember this? And then I was in a hinged cast for 2 months. So 4 months in a cast. And I came out and they grabbed me and they said, "Son, you might play ball again." It was touch and go. Believe me, it was like a really skinny leg with a long scar on the outside. But luckily, I did well and I recovered. A guy named Doug Henderson did the surgery, the Florida State team doc. I was in Tallahassee, Florida.
Right.
He did the surgery, and that was so neat that he used some tissue to make a new ligament in my knee. They actually did an arthroscopy later on when I was in residency and looked at it. It still looked great. But the fixation was the issue, which is why we had to use this cast for such a long period of time. So I spent the rest of my life figuring we need to improve the the fixation methods for ACL surgery, which Dr. Bergfeld was very instrumental in helping us with that. And so we've done a lot better at making that recovery, as he knows better than anyone, a lot better than it used to be. But so that was what I started with sports medicine. But when I went to med school, there was this little known thing called articular cartilage that I started doing research on in 1986. And no one knew about it at the time. I was taking cow, bovine knees, trypsinizing them, growing cells, working on growth factors. And I got 2 patents while I was in med school on some growth factors related to cartilage regeneration. When I got to my residency, they started to do this procedure called the Autologous Chondrocyte implantation procedure. And that's when that was a guy named Tom Minus, who was the one of the people who started that procedure in the United States of America. So I was with Tom Minus, and we started seeing this procedure. I got down to Louisiana, at Tulane, and I did the first cartilage implantation down here, first meniscus transplantation down here. So that's how I got my start down here at Tulane, doing biologic reconstructive procedures. Was also covering teams though, and in sports medicine, as Dr. Bergfeld was alluding to, we do a whole lot of different types of teams. I was covering believe it or not, in New Orleans we had a hockey team at one time. I covered the New Orleans brass hockey team. I covered multiple football teams. I was the New Orleans Saints team doc for 10 years. I won the Super Bowl with them in 2009, 2010. I still am one of the doctors for the Pelicans team here in town, the NBA team in town. One of my other partners does the predominant work with the Saints. And we have a whole lot of high schools and colleges we take care of. I now run a fellowship with three fellows per year. Trey was telling me one of his good friends is one of my former fellows. They finish their medical school, finish their residency, and then they come to do training in sports medicine with us. So as Dr. Bergfeld was saying, he didn't have the access to the fellowship, but he ran a 6-person fellowship, Dr. Bergfeld, Cleveland Clinic. You guys have?
We have 3 primary care and 3 orthopedic.
3, yeah. I thought you had 6 people, yeah. And so he had one. I have 3 operative fellows and 1 non-operative fellow, so 4. And then we have a research fellow, so 5 if you include them. So it's a big program. We have 70 athletic trainers that work underneath me now, a whole bunch of physical therapists and non-operative as well as operative doctors, both MDs and DOs working for us. We cover multiple high schools. My typical week when I was with the NFL team, like Dr. Bergfeld, it's very consuming. So it's Saturday, Sunday, you're basically out. Saturday, you travel to the game. Sunday, it's an all-day affair, right, Dr. Bergfeld? 9 to 5, right. You're with the team. The next morning is an injury clinic where all the injuries come in, and you go see the players and you figure out who's going to be, what status are going to be, what studies need to be done, who needs to have surgery, who's out for that week, who's in for that week. Wednesday of that week would typically be a day where we would give that status report that you see on ESPN, where they're probable, doubtful, that whole status that's provided to the public is provided to the coaches and the GM as well at that time. We then start the practices Wednesday, Thursday, Friday, a Saturday morning practice, and then on the plane again to the next site. So NFL coverage is a real time-consuming event. NBA coverage is a little different. There's 42 games you cover, home games you cover, and only home games during the season. If you make the playoffs, then you actually travel to the away games with the playoffs. So that's time-consuming during the playoffs. Not as bad during the season as the NFL would be, but it's a lot of games, obviously, 42 games, and it's basically 5:30 to 6 to, what do you think, 10:30 night, 11 o'clock at night. Yeah. Typical NBA coverage kind of situation. I also cover high school teams, and Dr. Bergfeld sounds like he did a lot of that. I cover a high school here in New Orleans that's pretty famous. St. Augustine is my predominant high school, but I have a whole bunch of other high schools I go and see as well. But St. Aug is my big high school that I really like. It's inner city high school here in New Orleans. It's really had quite a few NFL players come out of it, actually. Leonard Fournette, for example, is one of the players that came out of St. Aug. But that's a Friday night game or a Saturday game typically. That's not as involved as the NFL, but certainly fun. I'd say it's more fun than NFL coverage in some ways.
No doubt.
Yeah, so it's pretty exciting to see the kids play and have fun. And then usually during the season we have a Saturday morning clinic where we have an injury clinic, and everybody will take turns staffing that. That's the injuries that come in after the Friday night football games. And we see who needs what, try to get them going as quickly as possible for the next week's game. If they need, obviously studies, get those going on Saturday morning. I guess what were the other things we need to talk about today? I guess that's pretty much it. I do a lot of research, try to follow in Dr. Bergfeld's footsteps and do what I can. That's it. Thank you.
Great. Thank you so much. And last but not least, we have Dr. Reemley.
Yeah, well, appreciate it, Emily and Joan, for having us here. My background is a little bit shorter at this point in my career, but I'm from out west. I grew up in Idaho. I did my undergrad at University of Utah, And I went to osteopathic medical school in West Virginia. And I guess you're supposed to say West by God, Virginia. And then I did my residency in Toledo, where I really, I've always really wanted to do sports, but I kind of got my real sports bug there, being able to take care of the high school teams in the area. One of my mentors was one of Jack Houston's fellows, and we had a pretty good experience with him. It just kind of went into high gear from there. And actually, all three of our residents, myself, Dr. Fincham, that Dr. Jones was referring to earlier, and then my other co-resident, Dr. McCullough, we all did sports fellowships. So all three of us from that year did. So then after residency, I came to Tampa for my sports fellowship with Dr. David Leffers, who's been around for quite a while, 30 plus years in the Tampa area, who just retired. And got some great experiences with him. Our university coverage here that I am also taking care of now. We also take care of a Division II school, St. Leo University, and then multiple high schools in the area. Our athletic training program, we have, through our department, we have the Masters in Athletic Training program, and we are, quasi-faculty for them, and do all their training, and work with them when they're in the training room doing their clinical rotations. I've also do have clinic at Shriners, so I do a fair amount of peds sports through Shriners Clinic, and it's actually turned into a fair amount of cartilage work, as well as congenital patellofemoral instability and things like that we're taking care of. And I'm still doing the IT band over the top in my skeletally immature kids, and it's amazing how well they do. It's pretty good procedure. And then I've been hooked up with the trauma team from Tampa General, and I pretty much do all of their knee dislocations, multi-ligament knee reconstructions through the hospital. And I'm doing between 30 to 40 of those a year, so a fair amount. It's not for everybody, but it's one that I really love. My fellows really enjoy it, and the residents scrub, so they get a pretty good experience doing those. And it's a lot of fun. So my day, my week, usually Mondays is an OR day. That's when I do most of my elective cases, joints, total joints. I have a part of total joint practice as well, doing hips, knees, and shoulders. And then Tuesday's clinic day. It's my training room at our university, so I go there and see our athletes and everything there. Wednesday is a little bit surgery time in the morning for half a day, and then I've got admin in the afternoon to take care of some either medical student teaching stuff or work on some research projects with the residents and fellows. Thursday's clinic, and then Friday is my outpatient sports day. I have another partner who we split travel for football with, and then the rest of the season we're just covering all home games, both at our university and our Division II school. It's a lot of fun. I always tell everybody that this is something that I get to do. I don't have to do this. It's not really a job for me. It's just pure enjoyment, and I really always look forward to going to work every day, minus the time that I'm on call. But other than that, it's all right. So.
Thank you so much. And given that we have a number of students who are watching this, having so many experts, what do you think are the qualities necessary to succeed as an orthopedic surgeon? This is open to any of the four of you.
I was going to try and sneak in a story that people would have, but I think I can turn it into a lesson, because it's you have to be adaptable and you have to be willing to put in the work. But the adaptability, and I was chuckling when Dr. Jones was talking about his ACL and his cast, because I get to travel with USA Ultimate, and we were at the U20 World Championships in Wrocław, Poland, and there's some sort of medic which does not correlate to a US paramedic on site. And there is a hospital nearby that's a teaching hospital. And I know that because one of my colleagues at work works there, but a young lady had gone over to the hospital with a knee injury, and I didn't see her get injured, but I'd taken care of several other countries' athletes because I had my bag and somebody went down in front of me, I'd get hurt. And Scott from Australia, who's working in Scotland, comes to see me and says, I know you have cast shears in your bag. I was like, no, I have trauma shears in my bag. He said, can you come over here? This girl needs her cast cut off. What? I'm a physio. She needs to have her cast cut off. Like, all right. So I go see him. I've got my scissors and I see her coach. And her coach is a young woman who turns out is a Slovenian medical student and says, my athlete was injured. She tore her ACL and they put her in a cast. You sure she doesn't have a tibial plateau fracture? Are you sure she doesn't? You promise me she doesn't have a tibial plateau fracture? Because I have no access to the injury, no access to her x-rays. And at the time I didn't have an ultrasound. So yes, I have learned how to read ultrasounds. I carry an ultrasound with me at the field. I'm using it at work, but we take her over and it's a plaster cast. So it is a beautiful, Dr. Bergfeld, you'd be so proud of the plaster casting. And they casted her and we've got the water hose that we're using to fill water bottles and my trauma shears. And we cut and we get the cast wet and we pull it apart and we cut and we go another couple inches. And this goes on for 20 minutes. And we've got somebody from France hanging out. We've got the Slovenian team. We've got the Aussie and we've got me. We take it open. And now this young woman is about 17 years old. We get the cast off. She's bawling, absolutely bawling. Like, oh my God, she's got a broken leg. I'm completely broke. No, tears of relief. She was so thrilled and she'd only had the cast on for not even 24 hours. But you've got to be able to adapt and work in whatever scenario and with whatever tools you've got. I think I think we can all agree that we've got our share of stories of, can I have a, no, you can have this. Well, okay then. So I think adaptability and stick-to-itiveness are two of the biggest traits you need to become a successful orthopedic surgeon.
Thank you, Dr. Crowley, and I appreciate that story.
And I thought Dr. Jones, when I heard his story, I was like, oh my God, it's my girl.
About that cast on for 4 months.
Yeah,
it was a long ride.
Yeah.
You know, the adaptability, especially sports medicine, when I tell my orthopedic residents, you know, you're covering a game, but they may come up to you and tell you, I got diarrhea and you got to be able to treat it. So when I travel with a ski team, I was an orthopedic surgeon, but I had the whole gamut of things. And that's what made it really very, very good. You know, now with the training, it's so specialized and the guys, they don't have the internship. They spend the first year after medical school in a residency, second year. I had to do an internship and then I had to do a year of general surgery. And it made me, and I moonlighted in the emergency rooms. So I could do the orthopedics, but I could do all the other stuff too. So I felt very comfortable traveling with a team when I was the only one. And in the Navy, I went to sea for 5 months as a general surgeon. My billet, the Navy does funny things. I was an orthopedic surgeon, but my billet was general surgery. So while I was at sea, I did an appendectomy, a torsion of the testicle, a bleeding ulcer in the stomach. That one I didn't operate on. We pushed a tube down, let him get his blood pressure so low that he couldn't bleed anymore. But I was pretty comfortable with that because I had done all these other things and traveled with the team. So not everybody's going to go on a Navy ship. That's one other thing. Now, I think that when I went in, everybody had to go. I mean, there was a draft and you had to go. But without a doubt, it was the best experience I ever had. Medically, right out of my residency, I was the boss. I took care of admirals and football, Naval Academy football players, nobody else around. Now, we have one young guy who did go, in the Navy, he just got out of the Navy. He's so far ahead of half of our staff because he spent his whole time taking care of, you know, the Navy, they're all athletes, the Marines, young kids tear their ACL. It was just like he could do it with his eyes closed. And I keep telling the young people that, you know, maybe you're not decided where you're going to go. And with peacetime, it's a lot easier than but serving in the service, you know, you go there isn't a bad spot to go to. And it's a very interesting experience. Now, one bit, and he's back now on our staff, and he's arguing the same thing, but it's something to think about doing. As medical students, you have that opportunity, and it's 2 years. And when you look back on that 2 years, it would be a wonderful experience. Plus, you get to meet a whole bunch of people you would never ever meet, because as doctors, we don't really get to associate with guys who are generals and majors and these characters. So it was a wonderful, something I would say, just think about it.
Yeah, and I get to teach with Uniformed Services Health Sciences at their field exercise, and I've gotten to work with Dr. Fran O'Connor in the field.
Yeah.
I've gotten to know Fran, which is a pretty amazing experience. But it is pretty funny when you're out in the field, and I'm a civilian. Thank you for your service, by the way. Veterans Day is Wednesday, so thank you for serving, sir. But when the generals come up to you and they're like, "So I'm Eric Schumacher," and you're like, "Yes, General, how are you, sir?" They think that they just want to be considered another doctor. But it was pretty funny to watch them. But the kids at the University of Uniformed Services Medical School are pretty amazing kids, and what they're going to go do is what you're talking about. And some of them are very interested in sports and orthopedics, but they have to do some general time, which really helps. And I will say that the diarrhea, you travel internationally. Like, I don't do the NBA, I don't do the NFL. I travel internationally. I was in Kyrgyzstan and had I don't think it was a water problem. I think it was a GI bug, but I had to learn the words for loperamide in Russian. Loperamide. It looks really funny written in Cyrillic, but they say loperamide. And when I was you also have to play public, what's the word? What the people who are making us wear masks right now, the public health, you have to be able to figure out what's going on with public health, because we had a MRSA outbreak on a team because the guys were all one guy had a MRSA infection on his foot. I didn't even think about it until the next morning when I said, "Oh my God, they're all using the same shower." And we had to get bleach in the shower, bleach all their sandals, and get them all to wear their shower shoes. Because that's what you do when you're by yourself and you have an outbreak on a team. You have to do the general medical stuff, even though we're the orthopedic surgeons. I have friends on speed dial, even when I'm in other countries, that I can call. But you have to know your medicine to be a sports medicine orthopedist.
I think that's very difficult for the young orthopods now, because they had to decide to be an orthopedic surgeon junior year in medical school. That's when they apply for residency. They don't have any general experience. You come right out of medical school into an orthopedic residency, and you never rotate through where you might learn these other skills. And I think that's one of the stresses in sports medicine. And a lot of gals and gals don't go into it because they're uncomfortable in that environment. But if you do, it's easy enough to learn how to take care of the basic things. And I think that it's part of, you just need to know about how to take care of the medical thing. If you got a great operation, like with the Browns, I had John Lombardo, and I had Bob Dimeth with me. They were the docs. I had it pretty easy. I just had to show up when a guy tore his ACL.
Yeah, I would say that, and for me being young in that kind of boat that you're talking about, Dr. Bergfeld, it's limited on my basic medical knowledge. I mean, I take care of things, and I've got my high school teams that I am the primary care guy on the sidelines, but it is true. I mean, you're anywhere else, the primary care guys are there, and they still teach me a lot of stuff, and I think that's key as well, is for us, especially in I don't consider myself young, but in the younger career-wise, you've always got to constantly learn. If you're going through things and you're not learning, then you need to probably consider doing something else. And it's just a constant education for you every day.
Yeah, I got a lot of funny looks when I was at the AAN Sports Concussion Conference. They're like, "You're an orthopedic surgeon. What are you doing here?" Well, if I'm the one on the field, and I actually, it's pretty, when you're there on the field doing the immediate post-event concussion exam, you see some pretty neat stuff that you miss in the office even 24 hours later. And so you stretch your skills. And I think that's one of the cool things about sports medicine, is whether it's learning from Dr. Jones about cartilage restoration techniques, or learning, the Dewar's procedure for the chronic patella dislocations, or going and, I have to keep up with my concussion stuff, and I have to keep up with my what's the newest recommendation on the COVID return to play after COVID and heart evaluations. You have to always keep learning. I think that's, if you're not interested in continuing to learn, it's not a place you need to be.
Yeah, I think one of the things that helped me out was I was excited about anything I was doing. So you know, I was I guess I'm not as experienced as Dr. Bergfeld, but I had to do an internship in general surgery as well.
Good for you.
I'm that old, Dr. Bergfeld.
Okay.
I had to do a real internship, and it was painful. But I learned. I was in the emergency room. I was in the cardiac service. I was in the vascular service, the neurology service.
Yep.
I was, we had, and it's true. I never think about that, but I can handle anything with the GI tract.
Sure.
I can handle general surgery, and I did do a lot of moonlighting when I was in residency, and I moonlit as a general surgeon.
Well,
That's how I made money. Yeah.
The moonlighting, they all look down on that, but you think about it. You were in an emergency room all night by yourself.
That's right.
Everything that came in, you had to handle.
Right. I was handling MIs and the diarrhea, the whole stuff. It was everything.
Yeah.
You did everything.
Now,
Gunshot wounds too, but
And
the knowledge of emergency medicine, emergency room medicine, it's a whole separate discipline. They've taken that skill away from you. I don't think. Well, I know our residents don't moonlight in emergency rooms anymore. They've all have that. They have that all covered. I think.
Yeah.
I think. The other thing is you have to be willing. As I think Justine said, you have to be willing to learn. The Cleveland Ballet came to town, and we didn't have a ballet company. And Lyle McKaylee, some of you may know him at Boston.
I know Lyle, yeah.
Taking care of the Boston Ballet.
Mm-hmm.
So the manager says, well, Lyle, is there anybody there in Cleveland that could take care of ballet dancers? He says, well, this guy Bergfeld is a sports medicine doctor. That's as close as I. So I got a call. Now, I had never been to a ballet in my life. I had no idea what it was. So I went down there and said, they asked me, Dr. McKaylee has recommended you. You must be okay. We would like you to be our doctor. I went right to the bookstore and bought a book on ballet to learn first position, second position, third position, so that I didn't seem like an idiot when I talked to these dancers. And I really did my homework. I spent,
Good for you.
and I called Lyle up and I said, Lyle, what do I do? So that when I started running the clinics, I'd tell the dancers, let me see you do first position. Had to learn all those terms. Well, what I learned was that these are great artistic athletes, real athletes. So once I got involved in that and saw what they went through and how they trained, that was a lot of fun. And if I wasn't in sports medicine, I'd just be doing joint replacements or something. The great opportunity to do that in sports. None of the other disciplines in orthopedics will let you do that. If you're a joint replacement surgeon, you just go to the clinic, go to the OR. You're a spine surgeon. You don't do it. Sports medicine allows a whole opportunity to do a lot of fun things that take a little bit of work to get yourself ready for it, a little extra work. But I think that it's good.
Yeah, you can't be afraid in sports medicine to have some after hours work. That's the one thing you got to embrace and be happy about. You can't be sad that you're there. You got to be happy you're there. So because there's a lot of hours after 5 o'clock.
You're talking about your Saturday morning clinics now. It's changed, and I think it's for the better. But now with residents, family time is important, and
it is. Yes.
Family time is important. But we used to have our best conferences on Saturday, because Saturday nobody had clinic, nobody had the OR, everybody could be there, and now that's family time.
Yeah,
and I'm all for that. I'm not against families, and I think the residents were overworked. Being on call every other night's crazy. But it's gone a little too far, because you do have to give up some. And we're very involved in a residency program and sports medicine fellows, and it's changed dramatically. That I hear this family time, and it is right. It's important. Family time is important. I don't want you don't go say Bergfeld wasn't important, because I've got 2 girls and I have a wife.
Yeah, we didn't have the 80-hour work week when I was resident either. So and I finished my last year. I did a chiefship at where I did my residency, and it in the 6-month time, I did 500 cases. So it was awesome, man. You come out after that and then go do a fellowship after that.
Yeah.
And it's crazy the amount of training I had before I got to actually just be attending on my own. So that's the difference, I think, now. So
Yeah, well,
experience is lost.
I was in med school and starting residency when the 80-hour work week rule came out, and we kind of worked around it because we took call from home for most part, and I know that a couple of my best moments with attendings were on Saturday morning bumps and bruises clinic, where I had attendings that weren't quite sure what to think of me, and I came out of the room and I said, "This guy doesn't have a septic hip. He's either got an abscess or an SI joint problem." Like, "Are you sure, Crowley?" I bet my residency, and they're like, "Huh, okay." I was right. It was kind of fun. And then somebody said, "Why does a high school kid have a MRSA abscess?" I was like, "He's a high school football player in Oklahoma. Bet you he's using steroids." And I don't know whatever came of it. People like, "What do you mean, high school kid using steroids?" I'm like, "What do you mean you're not thinking about a high school kids injecting steroids into their glutes?" But my first weekend of calls and attending, I did 15 cases in 54 hours as an attending. So there has to be, you got to make room for life, but you got to know that you got to work hard. And there's going to be times when you can't. When I go travel with teams, I'm the only doc. When I'm international, I have athletic trainers that can get woken up first. But it's 2 weeks, like we do 2 weeks. That's one of the beauties of working at the VA is I can take 2 weeks and be there for camp and be there for the week of training. And your day starts when you go to the breakfast hall and people come ask you about their injuries or what they had going on during the night. And you may not get to bed until 1 or 2 in the morning if you got somebody that's sick at night. And you find time to enjoy an hour here. When we were in Australia, we took an hour. One evening we said, everybody that's not treated by 4, if it's not emergency, it's waiting till morning, we're going out for dinner. So we carved out a couple hours, and it wasn't a whole night, but we went out and had dinner on the Indian Ocean, and that's how we found our balance, was a couple hours of downtime to get back at it on Sunday morning when the tournament started. So you find your balance in small chunks.
Yeah, one of the other things that the technology is just unbelievable, and what we have available to us is technology. But in sports medicine, you still have to be hands-on. And I always say, use the technology, but don't let the technology use you. Because we're in the clinic and they know they got an MRI. You can pull the MRI up. You don't have to look through it instantly. And they've got the diagnosis made before they went in and talked to the patient. It's very easy to do that, but you have to put your hands on the patient. I can't tell you. They said that doc never even looked at my knee, just told me I needed to have my ACL repaired or I had to have my medial meniscus. You don't make that mistake. It's very valuable to touch the patient, and we have PAs, they help you a lot. You still, the patient and the athlete for sure wants you to be there as a doctor. You have to go in and talk to them, touch them, examine. Maybe you have your mind already made up, but you still have to do that.
Yeah, so many times throughout the day with med students and residents and fellows, I'm always telling them, treat the patient, not the imaging. And, that's something to always continue to carry on with them, because that's more important than anything else.
Well, the imaging things are so good now, though, you see how you could slip into that very easily.
Mm-hmm. Of course, yeah.
My joke with my patients when they're like, "Well, what's the MRI show?" I'm like, "No, when does your shoulder hurt? What makes it bother you?" Because I had a kid who came in who on MRI had a labral tear and none of his complaints had anything to do with his shoulder when you listen to his story. And I tell them the MRI doesn't feel pain. It's not active and it has no complaints. So I listen to their story and I know it's been being told since, Hippocrates. The patient will tell you what's wrong if you listen to them. Yeah. Imaging just confirms what they told you. Yes, I'm old school, Dr. Bergland. I listen to what the patient tells me and what their body tells me, and then I look at the imaging for the confirmation of how big is the tear. Is it a tear that can't be repaired? Is it not a tear at all? Is it Parsonage-Turner? Listen to the patients and then touch them appropriately.
I think that if I send a patient to a neurologist or something like that, they'll come back and say, doc, I'm not sure that doctor heard what I was saying, because he spent his whole time typing at the typewriter and looking at the computer while I was talking to them. And that's a big no. You have to look at the patient.
Yeah.
Just take, now, there's a lot of pressure on the doctors, on us as you as doctors, to get it done. You have 20 minutes. The administrators they've taken over, you take medicine back from them. Somebody figured out that you needed 20 minutes a patient. And so you're under pressure. You've got to get your notes done. And you can't yield to that. You can't ignore the patient, but it's not an uncommon problem at the Cleveland Clinic. Well, some of the departments have taken away the dictation, so the doctor has to type his own notes. Now, if you're really lucky, you have a scribe. The big producers have scribes doing the notes, but the young guy starting out doesn't have a scribe. He has to sit there and type his own notes. I couldn't believe it, but it's the way it is.
And I was just chuckling at that because I hear that complaint a lot too, and I tend to do my notes after work, but I will sit like this because my patient chair is over here and I happen to be left-handed, and I write down my important notes on a piece of paper. And that, we know from studies that what you write down goes into your brain differently. And because I'm writing, the perception is that I'm listening to them. If I was doing the same thing on the computer, and I'm of the generation where when I'm on Zoom meetings at work, they tell me to mute because I'm typing too fast. But when I write, when my patient knows I'm listening to them. When I type, they don't think I'm listening to them, even if I'm doing the exact same thing.
Absolutely.
And I know that when I write it, I remember it much differently. And it's something that I'm known for at work, is that people are like, oh yeah, no, Crowley knows how that happened and knows what went on with her patient. And because of the way I do it, my patients, I remember what's going on. So I found ways, I type fast enough that I can do it that way, and I hate dictation. You want to torture me? Make me dictate.
Yeah, well, I'm the opposite. I can't type worth a damn, but I can I do my dictation at the end of my clinic, and I scribble my notes. The nurses say, well, here's your scribbling stuff. And then I sit down and I can think about it, and I dictate much better than trying to dictate between the patients. And that's another one. Now the joint replacement guys have an op note. The only thing they have to put in there is the size of the knee they put. Everything else is automatic. Sports medicine is not that way. When you scope a knee, everyone is different.
Mm-hmm.
Everyone's got articular cartilage injuries in some place. The meniscus is torn. There's no format for that. Now, some of the guys think there is, but I can tell you it's not. And then when the patient comes back 2 years later with complaining, you've got an op note that may be very important to you. What was in that knee when you did it? So I used to say it's good teaching for the residents to dictate the op note, but I spent more time correcting their notes. So I just did my own notes. The residents didn't mind it because they didn't want to bother doing the dictation anyway. And they don't do it to the detail that you do it. So it's one of the other responsibilities that I think you can't get. The joint replacement guys can do that because all they need to know is the size, but not sports medicine.
And I think something else I would know from training, that I was expected to know my patient better than everybody in the chain. As a medical student, I had to know them better than the intern, the resident, and the attending. And I look sometimes now at medical student notes, and I don't know. I don't know what history they've taken.
Yeah,
it's just not the detail that was expected of me and that I expect of them.
Yeah, it is a challenge because my Wednesday afternoons I spend with second year medical students on how to doctor. It's called the doctoring class. And we go through histories and physicals and things like that. And it still continues to blow my mind at the difficulty with which they have in converting what the patient says into what's important in the chart and things like that. And I always tell them, for you medical students, it's each note that you write is a chapter in the book of that patient's medical history. And you need to have the amount of detail in there that is necessary, because if a colleague of yours picks up the chart the next time the patient is in or whatever, that they understand what your train of thought was, what your plan of care is, and what direction you wanted to take that patient, however, whatever their opinion may be, but they have that information, and makes it much easier and more of this continuity of care, which is so important today, in our patient care. So, you always need to look at that that you need a very, very detailed and concise note that has all the pertinent information to carry that note forward for your colleague who picks it up next.
A similar train, I joke that if I drop dead, my charting should be that if I drop dead tomorrow, you can walk into my clinic and figure out what the heck was going on with my patient. And something I learned when I was down at Tampa with Mba Coverage, when I have a post-op patient, the date of surgery and what the surgery was done is at the top of that note.
Yes.
Every post-op note. And if they come in a year later with a complaint on the same shoulder, what that surgery was goes on the top of the note. And the same for my fracture care. What day did you have your fracture? What day did you have your surgery? And what was the fixation?
Yeah.
Was it an ORIF with a long gamma nail, et cetera? But it's hard to separate charting. And I got certified as an orthopedic coder, so I could argue better with the coders at work. And I've learned a lot. I get bored easily. I'm sorry. I don't have children.
Whoa, an orthopedic coder. Wow.
Yeah. Well, I wanted to have a leg to stand on when I had conversations with the coders, and I've learned a lot, and there's a lot of changes. And it's also, but so like I told people,
how many peer-to-peer phone calls do you have to make now?
Yeah.
Oh, I have to review all of the before the chief that I'm covering for before he retired. Yeah, I got assigned to go through every provider's audit for the department. That was joyous. I learned about eyeballs and eyeball notes. Their notes are really weird.
Yeah.
I don't understand eyeball notes. But little things that people don't realize. When a patient walks into my hospital, into my clinic now in COVID pandemic land, they have a mask on and they're in my clinic, which means they've passed a screening. You can do a review of systems that adds to what you're doing that's actually pertinent, because if I'm going to have you signing consent for surgery within 30 days, would be kind of good to know that your wife was diagnosed with COVID last week. We've had providers who missed that, and then the patient shows up and turns positive and we have to cancel their surgery. And we're like, if you'd asked an extra question 2 weeks ago, 3 weeks ago, you would have known that to reschedule them then. And, so you can get histories. Oh, hey, you're wearing a mask. You got past my front door. No fever, no cough, no GI symptoms.
Yep.
And you've done a review of systems that you can document and code for that's honest. You're not doing fluff.
Yeah, and I think that
charting is a thing.
A good point, Dr. Crowley. Kind of in our last 10 minutes or so, I want to ask how your practices have changed in the last 6-8 months, given the COVID pandemic.
Well, I've been involved at my hospital in a lot of, and I volunteered because of my overseas stuff and my stair medicine to help out at our medical screening trailers when we thought we were going to get hit with the surge, which we're actually getting now that we didn't get 8 months ago, but helped rewrite SOPs, really looked at, I tweaked my notes to make sure my review of systems are there, to make sure that my, you have the conversation, are you taking all your precautions? Today I signed up somebody for surgery and had to go through the whole, you got to self-isolate, you got to quarantine. What does it mean? When are you going to get swabbed? So there's a lot more front loading. But again, with anything that we do, just like your instructions on whether you're in your hinged cast or you're in a hinged knee brace, what are the instructions and why are they following them? Because it's just expanding the teaching that we have to do before surgery. And I don't know what y'all are wearing for PPE at your hospitals. We are treating, even though we swab people, we're supposed to be wearing PPE as if people were positive. And I have failed 8 N95, so I get to wear a PAPR, a shroud-style PAPR to operate, and I'm not allowed to do any metal implants because they're not FDA approved. For the PAPRs, even the shroud-style, Ebola-style PAPRs are not approved for FDA approved for implants. So I am curtailed at what I'm allowed to do by my hospital because I can't fit into most N95s. So if somebody wants to take me up in a boxing match and help me out there, make it so my face fits. But that's how my practice has changed, is my surgical practice has significantly been changed by what I can do because of my PAPR N95 conundrum.
Dr. Jones or Dr. Bergfeld or Dr. Remaley, how has your practice changed at all during the pandemic?
I'm anxious to hear I'll say something, but let me hear the surgeons first because they're the ones affected more than what I do.
Yeah. So we've done, we shut things down during March, April, and then we started back up at I guess the end of May, towards the end of May. with surgeries. So we had to shut things down significantly, elective surgeries. I did emergency surgeries, but elective surgeries were shut down for about a month and a half to 2 months. Now we've started back up, and my practice, I've actually done more RVUs this year than I did last year, remarkably. I don't know how that even happened, but I've done a lot of surgeries this year, despite the pandemic in the phase after that when we started back up. We also have started virtual visits, so that's the thing that's really changed. Before the pandemic, I had never done a virtual visit. Now I'm very adept at doing virtual visits, which allow you to show patients the MRI and studies on their phone, meet with them about 15 minutes to 30-minute type phone conversation. We have our smart text and our EMR set up to document by virtual visit. Billing is done easily through virtual visits as well now. I think there'll be continued improvements in technology as we go forward. That's going to make it much easier for virtual visits to occur, but that completely changed after the pandemic. So virtual visits now are a continuing part and extension of my practice. So for example, an MRI result review, if I order an MRI on someone now, I'll have them come back virtually and do the virtual visit with them to go over the results rather than having them come back in person. Obviously limiting some of those in-person visits is good with the pandemic going on, and you can get a lot achieved without having to expose them or yourself. So that's a big change.
We've been doing the same with the virtual visits, which sometimes gets interesting in Appalachia, which is where I am, but.
Yeah, I mean, I'll preface everything by saying I'm in Florida. So you can imagine, Florida man and all of that stuff. But we were shut down from March until the first part of May. I'm the medical director of our surgery center at the university, and we only did emergency cases or cases that dealt with patients involved with their patient care. And so I'd have to review every case that went forward and everything. And most of them were just associated with our breast cancer specialists putting in ports and doing things like that are, absolutely necessary. And during that time, I did no cases from the middle of March to the second week of May, so 2 months. And every Tuesday and Thursday, my clinic was all virtual visits. I do find their utility for some things, but overall in orthopedics, they are tough because most of them, I call them consults with their forehead because, the patient sits there kind of like that. And, you really can't see much, but, trying to get them to show you their motion of their shoulder or their knee and things like that. So I use them pretty much now the same way Dr. Jones did for imaging review or just some generic post-op visits, from a knee scope meniscectomy and things like that. There are a lot of our patients, however, that come in, travel from afar, and there is some red tape in terms of us doing virtual visits with patients who are in North Carolina and California and things like that because we don't hold medical license in those states. Well, most of us don't. I mean, there may be some that do, but so you really can't help make a medical decision, I guess, so to speak, while you're in Florida and they're in some other state. So, but now we're pretty much back to full volume. I'm still down about 25% of my patient volume. That's part of the political thing of being at our university. They're still working on social distancing, and so our waiting room is shared with 3 other practices: cardiology, neurology, and physical therapy. And so getting all those patients to social distance in the waiting room and things like that, the university is still limiting our patient volume. So I can't say that I've done as many RVUs as Dr. Jones has this year, but so I'm sure by the end of the year, mine will be down a little bit, but it's definitely changed. I think mostly for the virtual visits and right now our patient volume. So
I wanted to hear what the surgeons had to say because I think it's affected their practices more than mine. But with an old timer that has a problem with their knee, if I have their x-ray, I can have them stand up and bend their knee or squat down. And I can get a pretty good feeling if it's an osteoarthritic knee, what to do. And but if I'm going to inject them with cortisone or hyaluronic acid, they got to come into the office.
Mhm.
So, and where I think it's really worked out though, and I think you said that's right. If I have a patient who I've seen in the office and I order an MRI, I can call them up and show them the MRI and say, here's what you need to have do, and here's what's in your knee, and maybe you need to send it to one of the guys that operate on you, or you need to come in for a cortisone shot. So
Yeah.
they're not the whole answer. They work. Post-op visits, I would think, would be just great because there you can look at the patient's wound, they can bend their knee, and you can talk to them. There you could do them very, very, very well. But it doesn't, orthopedics is one where you got to put your hands on the patient somewhere in the time. But they've worked out very, very well. As I said, our surgeon guys like it for the post-op visits, and I have it where I can report MRIs, but they usually get an X-ray before I see them anyway. But the MRI, I can show them the MRI, and that really pays off. So it's, in fact, now the other thing you were talking about your volume, and everybody has different financial things, and Cleveland Clinic was down to about 60% of the money they made. Okay,
Yeah.
we're back to 80% now. 80%, the bean counters. We're at 80% of where we were prior to the pandemic. And that's with a lot of guys working full time, but we still have not reached the same amount now. Apparently, I heard that this month was almost even compared to what they were before, but we're still behind. The other interesting thing was that one other institution reduced, it was on a salary, reduced the salary of the doctors by 10%
Mhm.
to make up for the deficit. And one thing about Cleveland Clinic, we didn't do that. We didn't cut any salary. We didn't lay off any people during this. So, and that's luckily there's a big endowment, and that's where they're covering it. But if you're out there in private practice working, and you got all these people you have to pay, it's a real financial stress by this, dropping back and not making it. And lots of my colleagues who are private practice have to let staff go, loyal staff. The only reason is they're just not doing the business that they were before. But we're up to about 90% of where we were before, but we were down at the height of it, 60%. And I don't think we'll get to 100%. There's still a lot of people nervous about going to the hospital. I don't want to go down there where they're treating all those COVID patients and get my hip replaced.
Yeah, and we had the same shutdown. We were up to not quite 60% surgical volume of where we were pre-COVID. Like with Trey, our biggest holdup is the social distancing in our pre-op hospital because the pre-day hospital, they just don't have the room for us. So we were slowed there, but we've had such a surge that in the Roanoke Valley in the last 3 to 4 weeks, we've had the highest number since the pandemic. Most of our hospitals have been on divert. And the middle of last week through this week, we had to cancel our to-be admitted elective cases. Our total joints had to get admitted, and any elective general surgery cases, and that does not include cancers, wounds, things like that. But we've had to cancel them, and we're looking, and we've been on divert a good part. And it's one of the things seeing the bigger picture. Our VA has a nursing home section. They've rearranged that and made this combined 2 floors into one to make an extra floor for COVID positive patients who need to be hospitalized but don't need to be in the ICU, because our COVID unit's been full. The big trauma center, Roanoke Memorial, has 2 floors of COVID patients. So we're really having a big surge and maybe having to cut way back again on our to be admitted. The difference for us now versus March is we have enough PPE, we have the SOPs in place, we have a testing protocol in place. We just don't have the hospital beds between people who put off their care, people who refuse their care, and the normal, it's wintertime and I'm going to have a CHF exacerbation or a COPD exacerbation. It's our numbers everybody's watching the numbers right now.
Yeah. Well, one of the things where the hospitals, several of the hospitals are at their maximum for taking care of the COVID patient. Now, one nice thing that we've done here in Cleveland, Case Western Reserve Medical School, and Cleveland Clinic has a medical school also. And we have a gigantic brand new building on the Cleveland Clinic campus that has Case Medical School and Cleveland Clinic's medical school and the dental school. There's a gigantic atrium there. They converted that to 300-bed hospital for the COVID. We got that all ready to go. We never had to use it, but guess what? They ramped it back up again. This big atrium has now become a big, going to become a hospital to handle the surge. So we're not too worried. We can handle the surge. We've got enough space, whereas most hospitals don't have the space to take a 25, 30% more COVID patients. It's an interesting cooperation between Cleveland Clinic and Case Western Reserve.
Well, to be respectful of time, I want to thank Drs. Bergfeld, Remaley, Crowley, and Jones for joining us this evening. It's been such a fruitful conversation about what it means to be a sports orthopedic surgeon. And I'm sure, like many of us students, we could just go on listening for hours. We really appreciate your time, and looking at the chat too, it's been really great to see students sending in their questions and having those answered. So again, thank you all so very much. Any final closing comments? Words of wisdom, advice for those of us going into orthopedics and hopefully sports?
I think we've all said it. We've really enjoyed being a practicing orthopod in sports medicine. We really like it. It's fun.
Thank you.
It is fun.
Yeah.
Thanks for having us.
Ditto. It's fun. Thank you.
Thank you. And this will be available for all of our student members on the website in the future as well for anyone to reference. Have a good evening, everyone.
Have a good evening. Goodbye.